Diagnostic validity of periapical radiograph and CBCT for assessing periapical lesions that persist after endodontic surgery by Kruse et al. In 2017. As we know that the goal of root canal treatment is to prevent or treat apical periodontitis, and when the primary endodontic treatment is unsuccessful, retreatment may be relevant, either non-surgical retreatment or surgical endodontic retreatment. Traditionally, healing after endodontic surgery is assessed by periapical radiograph. After Rudd and Mulvin introduced a criteria to evaluate the treatment outcome after surgical endodontics. Then, in the recent years, the use of CBCT had increased the diagnostic accuracy, especially in the follow-up after surgical endodontics. However, the true nature of inflammation of the radiographic lesion is unknown. So, the aim of this present follow-up study was to assess the diagnostic validity of periapical radiograph and CBCT in surgical endodontic retreatment cases that were reoperated due to persistent periapical lesion, using histopathology as a reference for the presence and degree of inflammation. 162 patients with 178 teeth had surgical endodontic retreatment with a follow-up period that ranged from 5 to 11 years, with an average of 7 years. 108 patients with 119 teeth met the inclusion criteria and were invited to participate in clinical and radiographic examination. However, only 74 patients with 83 teeth accepted the invitation, and the first baseline periapical radiograph were compared with a 7-year follow-up periapical radiograph and CBCT sections, and were evaluated by 3 observers, 2 endodontists and 1 radiologist. The periapical area in question were scored separately by the criteria proposed by Rudd and Mulvin: 1. Complete healing, 2. Incomplete healing, 3. Uncertain healing, and 4. Unsatisfactory healing. These classifications, as we can see in Table 1, were dichotomized into successful healing for score 1 and 2, unsuccessful healing for score 3 and 4. If the tooth was assessed as unsuccessful healing in periapical radiograph and CBCT, the patient was offered a reoperation, where the full volume of soft tissue of the periapical lesion was removed and histopathological examination was done, and classified as having no inflammation when there is scar-like fibrous tissue and normal appearing of bone fragment, or mild inflammation where there is fibrous tissue with slight infiltration of lymphocytes, or moderate to intense inflammation where there is fibrous tissue with moderate to heavy infiltration of lymphocytes, plasma cell, and granulation tissue. 33 patients displayed periapical lesion at 7 years follow-up. Only 23 patients with 23 teeth fulfills the clinical inclusion criteria. Out of the 23 patients, 3 patients refused the reoperation. So 20 patients underwent the reoperation, and Table 3 can show us the relation between radiographic and histopathological classification, which resulted in 8 teeth with no inflammation, which was 42%, 3 teeth with mild inflammation, which was 16%, and 8 teeth with intense inflammation, which was 42%. That means that with CBCT, 42% of scoring was false positive, with no inflammation in the area according to histopathological examination. In Table 4, it shows the relation between CBCT scores and histopathological examination. 6 out of 8 cases, which was 75% with no signs of inflammation, were assessed as score 3 uncertain healing, and with the score 4 unsatisfactory healing, there was 9 out of 11 showed mild to intense inflammation, and 4 of them reported pain and sensitivity to percussion. In the present study, more than 40% of the cases diagnosed as unsuccessfully healed at a 7-year follow-up showed no signs of periapical inflammation after histopathological examination of the periapical soft tissue, and these patients did not benefit from the reoperation procedure. Most cases assessed of score 3 in CBCT did not display any histopathological signs of inflammation, where the vast majority of cases assessed as score 4, inflammation could be verified by histopathology. Patient symptoms were a reliable indicator of an inflammatory periapical lesion. This parameter should be taken into account when dealing with the decision of performing resurgeries or observe the case further. It could be concluded that caution should be exercised when using CBCT for assessment of periapical healing after surgical endodontic retreatment.